Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Torres. Dr. Melissa Torres received her Bachelor of Science degree in Biology, cum laude from Salem State University. She continued her studies at Howard University College of Dentistry, where she received her Doctor of Dental Surgery degree, placing second in her class. She received the Dr. H. Norton Duhaney Award in Fixed Prosthodontics and the Department of Restorative Dentistry Award, along with being recognized for outstanding undergraduate achievement in the study of prosthodontics. She completed her postgraduate residency through the Advanced Education in General Dentistry program at Tufts University School of Dental Medicine. She is a member of the American Dental Association and the Massachusetts Dental Society. I would now like to request Dr. Torres to begin today's session. Thank you.
Thank you so much for having me. I'm so happy to be here today, and I hope you enjoy this topic as much as I do. And if you have any questions, please wait till the end. I'll be more than happy to stay on and answer any questions you may have. Great. Are we going to get started now? Perfect. Just let me know if you can see my screen there. Are we good there?
Not yet.
All right, just give me 1 second here. All right, let's do that again. Let me share screen. Can you see it or no?
Yes, now we can see it.
Okay. Perfect. There we go. All right, let me know. Are we good now?
Yes, thank you.
Perfect. Yay. Okay. So the art of dentistry, it's such an important topic for me. I'm super passionate about dentistry. I started off in dentistry at the early age of 15 years old. I went to a vocational high school while I took upon the trade of dental assisting. And that's how my whole life journey to dentistry started. It started that early on. And I already knew in high school that I wanted to be a dentist, and I had this clear vision of what I wanted to be and how I was going to get there. And obviously there was some bumps along the road, but I got there. So let's dive right into it. So my journey to becoming a cosmetic dentist. So a little bit about me. I am a first generation Latina. I grew up in a predominantly Latino community. My parents are from Central America. My dad's hardworking. My mom is also hardworking. They both graduated elementary and high school, but did not do any further education. So I was the first to graduate from graduate and postgraduate school in my immediate family. I was actually a dental assistant for 12 years before I became a dentist. So I have a lot of background in the dental field. I finished undergrad studies in 5 years. So I'm definitely not the typical, I didn't do 4 years of undergrad and I didn't go straight into dental school. I took a 2-year growth period actually after I finished my undergrad in 5 years. I took the dental admissions exam 3 times. And for those that don't know, after the 3rd time, you do need special permission in order to take the dental admissions exam. So thankfully, after the 3rd time, I decided to go ahead and apply. My exam scores were not that great. They weren't superstar scores, but I didn't let that discourage me from still applying to dental school. In fall of 2011, I applied and I was accepted to Howard University College of Dentistry, which absolutely changed my trajectory in life. It was such a blessing. Going into Howard, I was, just an average student. I struggled to find my path to dentistry in the sense that I didn't have any mentors or anything like that to help guide me. So I did a lot of research on my own and, tried to find as many mentors as I could. So again, don't let anything discourage you and just keep going. I placed second in my class and then decided to go to Tufts University Tufts University dental school medicine to finish my 1-year post-grad residency in advanced general dentistry. I did serve on both admissions boards at Howard and Tufts, so I do know about the admissions process of dental school and all of that good stuff. This was on my bucket list, and I've already done it twice. I was featured in Boston Magazine Top Dentist in 2019 and 2021 of this year. Super happy about that. And the rest is history from there. As soon as I decided to go to Tufts, I knew that I wanted to focus on cosmetic and restorative dentistry. So basically, what got me there and how was I able to execute everything and execute my goals and execute the vision, right? So let's move on. So it's going to require a lot of clarity and focus, right? A lot of clarity and focus to get you where you want to go from point A to point B. And that's all it is for any type of, program that you want to apply to, whether it's medical, optometry, dental school. You must know where you're going, what's the why, what's the purpose behind where you're going, and have a clear vision of that and who you want to become as that person. You want to focus on your plan A. Don't focus on a plan B to fall back on, because otherwise you'll never get to that plan A. I don't believe in a plan B. Just make it happen, take the risk, make mistakes, fail fast, fail forward. Personal development and mindset are everything. And that's the reason why I wanted to focus on this topic primarily first, because it applies to every single field, not just dentistry. Stay positive. You want to create great habits that are repeatable habits that you're able to implement every single day. You also want to stay disciplined. Discipline for me is such a major factor as to where I am today. And I continue to use discipline every single day of my life and in my career in dentistry. Your life, I'm telling you, your life will dramatically change if you just implement these couple things of personal development and discipline, clarity, and focus. All right, so we're going to dive right into self-discipline. So one of my best mentors, I don't know him personally, but through YouTube, his name is Jim Rohn. He talks about self-discipline. You have to master the art of consistent self-discipline. The application process going through dental school, medical school can be very rigorous and there's a lot of competition. And then as soon as you get into the school, it is a rigorous program. A lot of management of your time, learning how to manage 8 hours of a day and creating, maximizing and being efficient during that time. So what does it mean to master the art of consistent self-discipline? Setting goals, executing goals, managing your time. I don't want to hear, I don't have enough time in the day to study. I don't have enough time in the day. You do. You just have to be able to maximize the time that you have and plan it out. Leadership and relationships, fitness and health, happiness and wealth. All of this surrounds self-discipline. So keep that in mind. The discipline that it takes to make your bed every day is the same discipline necessary for success in the world of dentistry. Again, any field. All disciplines carry through to affect all parts of your lives. If you're disciplined in one area in your life, but are lazy in another, that lazy side will eventually creep and destroy the disciplined side. And that's just facts. All right, Leadership and Extreme Ownership. This is a fantastic book. I highly recommend, if you haven't read it, you read it. You don't love to read, learn to love to read, whether it's via Kindle, paper book, hard book, Audible, I don't care. Make this part of your daily routine to pick up a book or listen to an audiobook. This is great. And this is where I would recommend to start for leadership and how to own what you do daily. Take ownership in your actions. When you go into the dental field, you are going to be a leader in your field. You're going to be, whether you're an associate dentist or you decide to own a practice, you have to lead your team and you have to be able to lead your team effectively. When you're in dental school, you may have to be a team leader or a student leader. So it all starts with leadership, okay? Leadership is the ability of an individual or group of individuals to influence and guide members of an organization, right? So even when you're delivering treatment plans, you have to be able to lead or guide your patient to the most ideal treatment plan ever, right? Because that's what we're here for. Extreme ownership is a true leader that takes 100% ownership in everything in his or her domain, including the outcome, everything that affects it. This is the most fundamental block of leadership that cuts across all principles. It applies to leadership at any level in any organization. I think one of the biggest lessons that I've learned, I'd say within the past 2 years, is how to own what I do as a leader in the dental practice. Taking ownership of my team members' actions. Did I not effectively communicate that to my team? Did I not effectively communicate it to the lab that I work with? Did I not effectively communicate to my patients? So it starts at the top. You got to remember that. And if you're an effective leader, your team, your patients are going to be all stars. So highly recommend this book. I would definitely read it. Be obsessed or be average. I mean, I can't talk enough about mindset, and hopefully one day if I come back on here, I will focus totally on mindset. But these are just some of the books that I'd highly recommend as a dental student you start picking up. I mean, Atomic Habits, Creating Great Habits, The Execution Factor, How to Execute Goals. If you want to be a business owner, E-Myth by Michael Gerber, excellent book. It tells you how to take any type of business model that you would like and be able to replicate it over and over and over again, just like a McDonald's franchise. Millionaire Success Habits, again, there's nothing wrong with being a millionaire. It's what it will make of you to become a millionaire that's more important. The type of value that you'll gain along the way to become a millionaire, the value that you add to others to become a millionaire. So again, that's a great book. Start with why. That's how you find your purpose and what gets you up every single day and motivates you every single day to go to dental school, to study, to walk into the office and open the doors and see 10 patients to 20 patients a day. The Pillars of Dental Success by Mark Costas, an extremely great book about systems and strategies, about marketing a dental practice. If you're interested in opening a dental practice, all these books you should be picking up and reading. And if that was one piece of advice that I wish somebody told me when I was in dental school, it'd be this. The 10X Rule, How to 10X Your Life by Grant Cardone, and then just some other great, another great book by Dr. Anissa Holmes about how delivering a wow experience to your patients. Alongside books, I'd highly recommend that you start listening to podcasts. There are a ton of podcasts out there about, how to be a better leader. And it applies again to any field. The Dentalpreneur, Fee for Service Practice, Dental Practice Hero. There are a ton of Facebook groups that you should be joining. The Business of Dentistry, Fee for Service. I mean, there are a ton. How to build a side gig. Again, join them if you're very, very interested in being a high achiever. I'd highly recommend that everybody be the best they can be. So why not start now? All right, so we're going to dive in now since we kind of worked into the mindset aspect of personal development and why personal development is so important to become who you want to be. If you have that clear vision of where you want to be in 5, 10, 15 years, it all starts with mindset, and it all starts with a positive mindset, right? So that's how I got to where I am today. And that's the reason why I wanted to share that with you. So what is my definition of cosmetic dentistry? I mean, cosmetic dentistry is like so much fun. It's not only so much fun because I'm able to create art daily, but it's so much fun in the sense that I'm able to connect with my patients on a totally different level, to be able to execute and deliver like a whole brand new smile to them. And not only do that, but be able to build their confidence and self-esteem and overcome hurdles of the fear of the dentist that they've had all their lives, and they've been able to find that connection with me, and I've been able to connect with my patients. And I think that's the most important thing in dentistry, is to be able to connect with your patients, be able to make them smile again, overcome their fears. And that's the most gratifying part of my job, to be quite honest. So how I define it is, it's basically comprehensive dentistry that's life-changing, because I feel like I'm changing lives. I mean, I've had patients come in, cry in my chair, and feel like they were never able to smile again. They haven't seen a dentist in 15 years. Their husband doesn't know that they have severe gum disease, and they're like 28, 30 years old. And I'm going to change that person's life, because the person's going to not cry in the chair anymore. The person is going to smile again, and she doesn't, or he doesn't have to be ashamed of speaking or smiling or eating in front of people, or telling their husband or wife that they have severe gum disease. So that's why I believe that cosmetic dentistry is comprehensive and is life-changing. So a typical day in my shoes, it's pretty simple. So my days vary, and I work 4 days a week, and I chose to work 4 days a week. I used to work 5. In dentistry, it's a lot of like manual labor. It's a lot of manual dexterity. It's a lot of repeatable positions, a lot of talking, a lot of getting up and down. And I realized that 5 days a week just wasn't working for me. The hours were just a little bit too much for me, and I decided I wanted to cut down to 4 days a week. I do 1 night a week, but to cater to my patients, and I do like an 8 to 4, but the rest of my days are 7 to 2. So I'm going to focus on the 7 to 2. So normally I get in like around 6:45, and then I do a morning huddle with my team, and we just speak about the schedule itself, and then we target about, like, you know, are there any patient balances? Is there any pending treatments that patients haven't been appointed for? SDT, which is same day treatment. Do I have gaps in my schedule? Can anybody from the hygiene column be brought over to my column so I could do some treatment on the patient? Or are there any patients on the cancellation or wait list that could be put onto my schedule today, or any emergencies and such like that? So we're basically just touching base, kind of like getting all on the same page, so that way we function as a team and we look seamless to the patients that are coming in. We don't seem discombobulated, right? The procedures that I focus on are like restorative, white fillings, fixed prosthodontics, which can vary from like crowns, implant crowns, bridges, which I don't really do anymore. And we can go a little bit later on to that, but the wave of the future is implant dentistry. And let's just be real. You don't have to like prep adjacent teeth to replace one tooth. You're just putting an implant to replace that one tooth without having to touch the adjacent teeth. Porcelain veneers, composite veneers, and composite bondings, which I'll get a little bit later into that. So let's move on. The types of patients that I see that come in with complaints is it's pretty simple, because the way I market to my patients is basically cosmetic dentistry, right? But I still do comprehensive. I still comprehensively treat my patients, but a lot of them come in, I hate my smile, I have chipped teeth, I hate my gaps, I hate my spaces, I feel like my teeth are short. One day I woke up and now my teeth are really short. Maybe they're grinding, maybe they're clenching. They've never been told that before. My teeth are uneven. I get a lot I've been in braces maybe twice. I don't want braces anymore. How can we straighten my teeth without doing braces? You know, yellowing up the teeth, which is a little bit of simple, you know, you could do some whitening. I'm super insecure about my teeth. These are the patients that come in, usually haven't been to the dentist in so long, haven't been able to find a dentist that they feel comfortable around. And also, they're the type of patient that may cry in the chair. So there is a psychological component that in dentistry, you have to be able to communicate with the patient and help guide them through that fear, because they're anxious, they're insecure, they're afraid, and you and your team have to work together to make that patient feel comfortable. So yes, there's a lot of patient management that goes into these cases, because it's super important. When a patient smiles, especially now when they're on Zoom, all they realize is the color of their teeth, how they look. Oh my God, I can see wrinkles around my lips. Oh my God, my teeth are crooked. Oh my God, this looks horrible. So you can't be like, oh yeah, I agree, that looks terrible. Like, you have to be able to learn and be compassionate and empathetic, and your team also has to be on the same page to help these patients. Okay, so what are we looking at here? So basically, this is called a lingual template, where you can see the right tooth is broken in half, right? So how are we going to rebuild this tooth back up? And a lot of the times, I personally don't use this lingual template. Lingual just means tongue area. I personally like to build up my teeth from scratch, but sometimes if that fracture is very big, I do use some type of template, because it does help the procedure go a lot faster. So treatment planning and case selection basically is super important when you're delivering and or treatment planning patients, right? The face is going to be the main, basically the main thing that you want to look at when you're treatment planning patients. You want to create the treatment plan based off the facially driven position, is what we call it. So you're going to need photography, preoperative photography, intraoperative photography, and postoperative photography when you're doing these cases. Smile mock-up, I'll show you a video. All it is basically, teeth are really short, teeth are in different positions. You're going to basically take material and make the teeth where they should be in relation to where the patient wants their teeth, right? Or where I envision where the patient's teeth should be, or where I envision, should they be more masculine in shape? Should they be more feminine in shape? Where should these teeth be positioned in relation to the face? You want to carefully select your case, and you want to set patient expectations, because some of these patients that are coming in for cosmetic dentistry have really, really high expectations, and they may not be realistic. May not be realistic in the sense that maybe all their teeth cannot be saved. I mean, maybe these patients need dentures. Realistic in the sense that patients exacting. Patient has unrealistic expectations and wants her or his tooth moved slightly with the veneer, but just one veneer, but the patient needs 4 veneers. Some of those patients you may not want to treat. And if you feel it in your gut that you shouldn't be treating that patient, maybe you shouldn't treat the patient. Not every patient and doctor relationship works, and it's okay. If it doesn't work, it's better off. You sleep better at night. All cosmetic cases in my practice will always get a night guard, whether or not you grind. I'd say 95% of the population these days are grinding and clenching their teeth and cracking teeth, especially with the pandemic. The pandemic has caused an increase in stress in patients to the point of no return, where they're breaking teeth left and right. Okay, key points in treatment planning aesthetic cases. I'm not going to get too in detail here. Again, if you know, there may be different levels of students here. If you have any further questions, you can let me know at the end. But incisal edge position, when you're looking at the incisal edge position, all it means is that you're looking at the edge of the teeth, okay? You want to look at your lip display at rest. So when the patient is at rest, you want to say Emma, and then you'll be able to see if 1 to 2 or 3 millimeters of tooth structure on the top teeth are showing. Lip mobility, does the patient have really high lip line? Meaning, does the patient have a high gummy smile, or does the patient have a normal smile? The upper lip lane, the longer the lip, the older the patient will look. It's just one of those things. The elastin, the collagen, everything just tends to drop down with gravity as we age. The occlusal plane, again, it's just where our teeth are. Are our teeth nice and straight, the edges, or are they canted, or are they all over the place? Lip asymmetries, a lot of patients are getting lip filler to correct lip asymmetries. Sometimes lip filler can cause lip asymmetries. Lip volume, teeth positions, are they in the correct position? Do we need to put them in the correct position? Buccal corridors, when I smile, the black lateral space, that's called a buccal corridor. The more full it is with teeth, think about a Colgate smile, nice and wide. A lot of patients are looking for that. Like I have buccal, you can see the black spaces. I mean, I don't mind it, but some patients hate it. Gingival contours is gum contours. Are they even? Are they uneven? And then you're going to be looking at the shape and the shade of the teeth. All right, this is actually a case that I did. It's very natural. The two front teeth were really, really short, but I just wanted to use this picture to show like the average length of the central incisors, which are the two front teeth, and then the average length of the average width, I'm sorry, of the central incisors. And you know, when you're starting to do cosmetic dentistry, I didn't put all the front teeth millimeter insides, but you should have like an average idea of how long these teeth should be for a woman versus a male, and be able to create, you know, the shape, the size, and all of that to make sure that the final result is exactly what you envisioned for the patient's face. Patients are square, some patients are ovoid, some patients are oval, round. All of that's going to dictate how the teeth look, the shape of the teeth, the shortness, the length, all of that. All right, so here is the smile trial that we have. So let me just play the video. You may not hear audio, you may. So a smile trial, basically what I'm doing here is I'm recreating the shape of the teeth in the chair for the patient so he or she can see it right there and then. A lot of the times I do this in the hygiene chair. I'm just using composite material, which is white filling material in a flowable form, meaning it's viscous. So you can see there it's very, very liquidy. And I light cure it, and the patient loves it. And it's an automatic way to close the case right there in the chair for the patient, especially if the patient's been thinking about this for like 10 years. Finally, they see it right there and then, and they're like, I want to do this. They book the next appointment, and you see them like 2 to 3 weeks later to do the actual bonding or the veneers, whatever you have planned. So the camera that I used, I specifically use a Canon SC Mark II with a macro lens of 100 millimeters and a macro ring light. That's the camera that I use, and all the pictures that you see here will be taken with that camera. Okay, the setup that I use is pretty intricate. If you have any questions, let me know at the end, but you know, it's a basic cassette. I use a plastic instrument. This is specifically for composite veneers. I use polishing discs, polishing burrs, strips, you know, bonding agent. I always compare it like to a person that doesn't know what I'm talking about. I always compare it to like getting your nails done at the nail salon, or like acrylic tips. It's a very similar process that could take anywhere from like 90 minutes to 2 hours. This is specifically for composite veneers. It could take longer depending on how many teeth you're actually doing. Again, my burrs that I use and the handpiece, I use a slow to polish, and I use the high speed for like the finishing. Sometimes I use it for the polishing too. So on the left there, you see there's a measuring tool that I use before I start my cases, and then after I start my cases, or even during the process of my cases. It measures in millimeters, and then I'm able to see how much length I need to add. Are the teeth even? The gum tissue is where the gum tissue, where I want it to be. On the right, it's where I use for like my shade selection of teeth, like where do I want the teeth lighter? Do I want the teeth a little bit darker? Do I want a mixture of colors? And then if the teeth are a little bit yellow, this is the product that I personally use. I like Opalescence. Opalescence Go is just non-customized trays for patients. It comes in a pack of 10. And then on the left there, you have the actual syringes, which is, you can put into custom trays for the patient. All right, so we're gonna jump right in to emergency class 4 fractures, okay? And for those that don't know what an emergency class 4 fracture is, you're looking at the angle at which the tooth is fractured. The angle at which the tooth is fractured is at an angle there, and it only includes certain surfaces of the tooth. That is what a class 4 fracture is in dentistry. This particular patient came to my office. She tripped and she fell on concrete. She didn't lose any consciousness. I always check any type of soft tissue to make sure that no tooth fragments are in the lip. This is very important for the medical students as well, because sometimes you'll see emergency cases in the ER where the patient might have fallen and the dental office is closed and they think that it's a life-threatening thing, and then they come to the ER and you'll see this with blood everywhere. I mean, all you have to do is just make sure that, there's wipe away the blood with gauze, check the teeth, check if there's any mobility of the teeth. These teeth were not mobile, so I did not have to splint the teeth. The type of splint that you would use in the ER would be a non-rigid splint, something that's very flexible. And what you normally do is you want to extend the splint normally two to three teeth beyond where the fractures are or any type of mobility is. I mean, I don't know in the ER whether or not they would have like composite material. That's the type of material you would use to bond the splint onto the teeth. Some oral surgeons that are in hospitals that serve the ER sometimes will have this type of material, but it just depends. The other thing that you're going to be looking for is obviously jaw fractures, making sure there's no jaw fracture. And most of the time, if there's a jaw fracture, patient can't bite down. The patient will say, I can't bite. And that's when you're thinking probably some type of condylar fracture in the jaw or the mandible. And that can obviously be very painful. So oral surgery, whoever's on call for oral surgery should come in for that. The other thing is the soft tissue. Again, you want to be looking for any soft tissue fragments in the lip. If they are in the lip, you want to remove those fragments from the lip, and then use any sutures. Any sutures to suture up the lacerations in the soft tissue. If it's pretty deep, you obviously want to start at the muscular portion and close that up, and then go more superior, more superficial, and then close up the layers as so. So in this case, it was a little bit more simpler than that. I didn't have to do any of that. The patient didn't have any foreign objects in her lips. None of the teeth were mobile. It was just simply aesthetic fracture. With these type of cases, however, you always want to forewarn the patient the teeth may become dark, the teeth may lose vitality, meaning the teeth may die, and or the teeth may need root canals in the future due to trauma. Anytime a tooth is traumatized, you have to remember the nerve will either repair itself or it won't repair itself. I just saw this patient. I saw her 2 months later. The teeth are still vital. I will check next year and I'll keep taking x-rays to make sure that nothing changes around the apex of the tooth, meaning the root of the teeth, and make sure that the teeth are still alive. Okay, so this is basically the process of where I'm going to start building up the teeth. So you can see on the right, I already started building up the right tooth. The left tooth in the middle, I'm already building out the lingual shell. So that's what I was talking about. You see how the back one was missing, and then this one is now like the lingual portion, the tongue portion of the tooth is now there, or I should say the palatal shell, because it's in relation to the palate. And then I'll just start layering the composite material on top and then polish. So this was the final result. I think this was a great result to where she was actually starting, which was right here. And I just saw her again like last week, and it looks really, really good still. So yeah. So this is called a diastoma gap closure. Diastoma also means gap. So if I keep saying diastoma, now you know. So the diastoma closure, you could see in the middle there, she had a white filling material, well, now yellow. That was very uneven. Her midline was shifted to her left or your right on the computer screen. You can see tooth number 8, which is the left tooth, is a lot wider than tooth number 9, which is the right tooth, right? So I had to make sure that I shifted her midline to the left, even out the teeth, so that way it looks more proportional to her face. I personally really like the shape of her teeth because it really matched her face. Just her two front teeth were just not proportional to her face. The shape of her face, her feminine structures, it was like a lot more square, chipped in the middle, and I didn't like that yellow bonding that they did. So she came in specifically, she hated her gap. She was really, really healthy. Medical history was within normal limits. Dentition, meaning her teeth were great. She didn't have any cavities. She just had that diastoma between 8 and 9 and some fractured bonding. So again, I wanted to shift her midline to her right or to your left and correct the bonding. So there it is. It looks fantastic in my opinion. So you can see here, we made those two front teeth. I shifted the midline to her right. I removed that old filling material. Now, if you can see where her midline is in relation to her bottom teeth, now it's dead on. Before it was to her left. And I was just like, no. Highly polished, looks super natural, not invasive, no veneers were done. And this was done in I'd say less than 70 minutes. And the patient was able to leave with this smile. And this was the smile reveal. I absolutely love it because it's like, it looks so good. Like the shine and everything, it looks so natural. All right, so this was another case that we did. This is an aesthetic bonding case. So this patient came in and she was really unhappy with her smile and her chips in her front teeth. She actually had a very good bite, meaning I think she might have chipped that tooth maybe with a fork or something. It doesn't seem like she was grinding or clenching her teeth, because a lot of the times patients who grind and clench can actually fracture teeth. She has a little bit of natural wear on her teeth, but I couldn't find anything that was like actually causing that fracture, right? So we went ahead and we did the bonding. And as you can see here, it's very, very, again, non-invasive, able to blend out that material so nicely. That way you can even see where the filling meets the tooth. It's that nice. It's like you're literally, a person on the street or a lay person wouldn't be able to tell which teeth were actually worked on. And if I'm actually not going to even tell you which teeth were actually worked on, because is it 1? Is it 2? Is it 3? Is it 4? Like, I believe the art of dentistry, like, and 4 years ago, I wasn't as proficient as I am now. And I just plan on getting better and better and better for my patients to deliver that higher quality care I can every single year. The better I get, the more value I can add to my patients. So yeah, it looks really good. Here's another case. This is a different case. So this patient, you can see the amount of wear and chips she has on her teeth. I recommended this patient actually get Invisalign. The reason why is because patients, they have overbites, right? Now, the overbite in a patient, the tighter the overbite, the more restricted their actual bite is, okay? If you think about it, the amount of movement she needs to get to this position, if you're looking from the side of the teeth, it requires her a lot of movement. If she's from here, it's less restricted. So she's in a restrictive state, which is called the restrictive state of restrictive envelope of function. That's what it's called, the dental terminology. And that's the reason why she keeps chipping teeth, alongside that, you know, her bite is a little off and she's not wearing a night guard. This is actually a good friend of mine. So I told her that I would do the bondings, and that if they chip, that she knows why they chipped, because she didn't get the Invisalign, but I was willing to adjust her bite and do some experimental work to see if the bondings would last. So I did this case, I think twice, because the bondings on some teeth kept chipping. And it was A, she wasn't wearing her night guard because she kept traveling. And then B, most of it, operator, right? Take ownership, right? The bite was a little off. So I had to adjust some of her lower teeth to kind of free up the space so she wouldn't keep hitting her teeth and breaking the bonding. So this is the longest it's gone without having her break her bonding. So Let's see. All right. Dentistry is definitely a learning experience and how you get from point A to point B and how you get better as a clinician. So she didn't like her chipped teeth. Her medical history is great. She did have decay, fracture of her anterior teeth, which anterior means front, grinding, clenching. I wanted to adjust her bite and fix the chipped teeth with bondings. And she did agree to do Invisalign in the future so we can correct the issue, because the bondings is basically just a temporary solution to an actual problem that needs to be addressed. And this is how it turned out. I mean, I think it turned out great. Her bottom teeth are shifted. She didn't want to correct the alignment of her teeth. We will correct the alignment with her teeth with Invisalign. I'm going to show you a video of what it looked like. Again, these are my favorite because they look so good. Like in person, it looks so natural compared to what she had before with all the chips and everything. She gets so many compliments and she refers so many patients. So I'm so grateful for that. This was actually a very difficult case. This patient found me on social media, and she doesn't smile. She hated to smile. You can see she has a very restrained smile because she was actually very not happy with her smile. She has a lot of chipping. Very young patient. If you were to look at this patient and you didn't see her face, you would think that she was a lot older than what she really was. And this is what I was talking about. I mean, she had a lot of wear on her teeth. Her lip was really low, and that's most likely because she was guarding her smile because she didn't like it. She had gaps. She had a lot of movement in her teeth. She wasn't interested in braces because she ought to had a round of braces. So this is the type of case that you have to set patient expectations. She has to wear a night guard. If she doesn't, she will break her teeth. This case should have been a veneer case. However, the patient could not afford it. So we compromised with doing composite veneers for the patient. Again, didn't like her smile. She did have cavities. She had fracture of her anterior teeth, diastomas of her anterior teeth, crowding. I adjusted her lower teeth to compensate for that. And I also did the composite veneers in the top, and I did 6 teeth. I don't know what that was. Did somebody right there? There we go. This is the final result. I mean, I think that looks really, really, really good. I mean, look at that. We did 6 composite veneers, very natural. This was all additive, meaning I did not remove tooth structure. I just polished, kind of finished and roughened up the surface, just like you would a nail if you're putting gel polish on. And yeah, she was extremely happy. Look at I want you to look at where the lip line is in relation pre-operatively to post-op. Okay, how the difference in the smile. You see how much lower her lip is in this smile? It's like, look at this. You could see her gum tissue now because she's smiling a lot more confident. She's happy that she can smile again. And that's the type of things that you see in cosmetic dentistry. It's amazing. I mean, it's more the satisfaction for me, obviously, is seeing this beautiful piece of artwork, but the patient so happy is like the best feeling in the world. And this is the video of her final result. I mean, so good. I'm like the biggest cheerleader for my patients. I'm like, oh my God, it looks so good. I think we're near the end, guys. I think we're near the end. Okay, so success is nothing more than a few simple disciplines practiced every day. Again, Jim Rohn, my best mentor ever. I don't know him, but if I did know him, I'd say thank you so much because he offers so much value. And I'd highly recommend, if you haven't, it's ROHN. If you haven't heard his stuff, go on YouTube and start listening to his stuff like today. And yeah, thank you so much. I hope you guys enjoy this topic as much as I do. I'm super passionate about it. If you have any questions, you can email me. You can find me on social media. And yeah, thank you so much.
Thank you so much for your kind advice, Dr. Torres. If anyone has any questions, they can feel free to ask now, and we'll now begin our Q&A session. So our first question is, what should our general oral hygiene regimen be?
So generally what I recommend patients is you want to brush 3 times a day. 3 times a day, once in the morning, once after lunch, and dinner time. If you can't get the second brush in, it's good. Most of the patients brush twice a day. 3 times a day is ideal. And you want to floss right before bedtime. You do want to brush your tongue once a day. A lot of bacteria builds up on the dorsum of the tongue, which is the top portion of the tongue that you see. You could do it with a tongue scraper and or a toothbrush. Different types of over-the-counter products that I recommend to patients is if you have a higher risk of getting cavities, you want to implement some type of fluoride treatment, whether it's a mouth rinse and or toothpaste that has fluoride in it. Fluoride decreases the amount of, helps decrease the amount of cavities in the mouth, helps remineralize enamel. Other products is hydroxyapatite. It's like the substitution if you're not into fluoride. There have been some literature out there that states that it's as effective as fluoride, but hasn't been on the market as long as fluoride. Also, different things for patients that may have suffered gingivitis. There's different products. Patients who suffer dry mouth, there's different products for that too. So typically that's what I recommend to my patients.
Thank you for that really detailed advice. Our next question is, given that you decided to pursue dentistry starting from high school, growing up, how was your relationship with your dentist and how did their role shape your path to cosmetic dentistry?
So I think how it shaped my decision to become a dentist was my dentist was a Caucasian male, a pediatric dentist, and he was really funny. But I just remember these huge, big, old male hands coming at me, really rough, like friendly, but a rough. So I think from that aspect, I wanted a dentist that I was able to connect with, that was gentle and funny and fun and vibrant, and just super friendly and understood who I was, right, and where I come from, and what I envision in my teeth. So that's how I envisioned myself as a dentist in the future. So I think from that aspect, I was like, I'm Latina, I'm not male, I'm not Caucasian. I wanted to break barriers. I wanted more underprivileged minority, bad, I don't know if I can say this, but I'm going to say it, badass females out into the fields, and getting out there. So that's how it shaped my decision to become a dentist. So yeah.
Thank you for sharing your personal experience. Our next question is, so there was a TikTok trend last year where teenagers were damaging their own teeth, like shaving down their teeth with nail filers in
Oh
order
my
to
God.
receive,
Cringe.
veneers or crowns. And so there have been misconceptions between veneers and crowns. And can you speak more about the differences between the two?
Sure. So that TikTok trend was like, so people have what we call mamelons on their teeth sometimes, which are like these little bumps, and they're very natural. And that's how teeth come in. And as you age, they're supposed to flatten with time, but sometimes depending on the patient's bite, those mamelons or bumps stay on the teeth. And I think the TikTok trend was to get rid of those bumps. And it like makes me cringe because if you remove too much of what you call the enamel, it can cause sensitivity because you're already into the dentin, meaning the second layer of tooth structure. So I highly do not recommend that. What was the second part of the question?
Can you speak more about the differences between veneers and crowns?
Yes, for sure. So a veneer, right? And it's going to depend on the patient and the teeth and how it's going to depend on the treatment plan of the patient's teeth, right? So a veneer is basically like a contact lens that sits on top of the tooth. That's the best way I can explain it. You either have to reduce tooth structure to the front of the tooth to make that contact lens fit on top. If the tooth is deficient, meaning say if my tooth is really, really flat and I want to bring that tooth out, that patient does not need reduction. That patient needs addition, meaning that patient will not have to reduce their tooth. So there's a misconception saying, oh my God, if you get veneers, you're going to ruin your tooth structure. Not necessarily. It's called a prepless veneer, and only some patients qualify for that prepless veneer, where they require no reduction of tooth structure. They just cement that contact lens, aka veneer, onto the front portion of the tooth. I don't want to say these procedures are reversible, because whether you get a composite veneer or composite bonding, porcelain veneer, to me, those type of procedures are irreversible, because whether or not you don't touch the tooth, you're still cementing something onto your tooth. It may alter your tooth structure in some way, not heavily, but it's going to alter it, right? Long term. The difference between a porcelain veneer, a composite veneer versus a crown is completely different. A crown encompasses the entire tooth. Just think about a hat that, or like I'd say like a bag that would sit all over your head, like encompasses the entire tooth. You do have to remove tooth structure for this, okay? When you remove tooth structure for a composite veneer or a porcelain veneer, it's like tenths of a millimeter. I'm talking about you're removing 0.5 millimeters to a millimeter of tooth structure, if that. I'm talking about literally small, 0.3 to 0.5. A crown, you're removing 1 to 2 millimeters all over the side of the tooth, and then sometimes 3 to 4 millimeters on top of the tooth. So you're removing a good amount of tooth structure in order for that cap or crown to sit over it to make room for the porcelain. Why would a tooth need a crown? If it's getting root canaled and there's more than 3/4 of the tooth structure gone, it's recommended teeth get crowns when more than 3/4 of the tooth is missing. I mean, it's at that point it's compromised. Root canal teeth, severely decayed teeth, if a front tooth is severely broken, you may want to put a crown on that versus a veneer. So that's the difference.
Thank you so much. Our next question is, does whitening have any negative side effects on your teeth? And would you recommend doing it multiple times a year?
So whitening can have negative side effects in the sense that if you over whiten your teeth, you could weaken the enamel and cause sensitivity, okay? I know patients that whiten weekly and they have no side effects, they have no sensitivity. I personally cannot whiten weekly. I only whiten once to twice every 2 to 3 months, just to kind of keep up with it. But my teeth are super sensitive, and it's gonna be dependent patient per patient. So long term, is it very damaging? No. Is it going to cause irreversible damage to your teeth? No. But can it cause long term sensitivity? Yes. For whitening, I would say customize the whitening to your tolerance. So if you can only tolerate once a month, once every 2 months, once every 2 months. If you want to do a touch up once a week and it doesn't cause any issues, then it should be fine.
Thank you for that answer. Our next question, more about whitening. What is the difference between like a whitening strip from Crest, for example, and the whitening procedures you perform in the office?
So whitening in general, the main ingredient in whitening products is either going to be a carbamide peroxide or a hydrogen peroxide. The main difference between the product itself is going to be the actual percentage that is used in the product. So what you're going to find over the counter products is going to be a lower percentage than something you're going to find in a dental office. Dental offices can carry up to 40% in hydrogen peroxide or carbamide peroxide. So that type of peroxide is going to be a higher percentage, and it could definitely burn the tissue, burn the soft tissue. So that type of percentage you do not want to use at home, and B, you will not find over the counter because of the amount of acidic or chemical burns that could occur without proper monitoring of a dentist. So that's the main difference.
Thank you. And as a follow-up, what is the recommended fluoride concentration for mouthwash, and is it available over the counter?
Recommended percentage of fluoride. That is a great question, and I don't actually know the actual percentage. So I can look that up for you though. I don't know the recommended percentage.
No problem. Thank you. Now,
It's part. All I know is it's parts per million. So it's like 100 parts per million. Let me check. Okay, I'll check.
Thank you. And now I will pass it off to Hamza to complete our Q&A session.
Sure.
Actually, I'll pass it off to Zaid to continue our Q&A.
All right, thank you, Amna. So for our first question we have here is, what is the difference between porcelain and composite veneers? And is one type of veneer preferred over the other in certain cases?
So the main difference between a porcelain and composite veneer, let's start composite. So composite is going to be a lot more affordable price point for a patient. You're going to see immediate results that day, meaning the patient's going to come in and they're going to be done 2 hours later, and they're going to leave with those veneers. Okay. Composite veneer is just a fancier term for a white filling veneer. It's the same white filling that you would put in the back tooth with the cavity that you are going to put in the front teeth. The technique is a little different in the sense that you may do different layers of different colors of the actual shade of composite, and you're going to put anatomy, you're going to polish it. Okay. It's porous, will pick up staining. It's not as strong as porcelain. It will chip, and it only lasts between 1 to 7 years. I mean, I've seen these composite veneers start chipping and or staining within 3 years. So you have to tell the patient that off the bat. The patient wants cheaper. That's what you're paying for. You're paying for a cheaper product that's not going to last as long as a porcelain. Does it look great? Yes, but you have to tell the patient, set the expectations before you move forward with that procedure. Porcelain, however, is different. Porcelain is a better product. Obviously, it's porcelain, so it's stronger. It's non-porous, so it's not going to pick up staining. It's cemented onto your tooth versus bonded on with a chemical bond. It's going to be cement that actually cemented onto your tooth. Most of the times with porcelain veneers, tooth structure does have to be removed. But they last upward 10 years, like beyond 10 years, because the product it's better. It could be anywhere from like $2,000 to $3,000 per tooth versus a composite veneer is $600 to $800 a tooth. So it's significant, but you're paying for the product, you're paying for the porcelain, you're paying for a long-term solution, which is going to last longer.
Thank you, doctor.
Mm-hmm.
And we had one of our students ask about differences in gum color. So how can a doctor tell whether the difference in gum color is a normal variation between patients or something of concern for a medical issue?
That's a great question. I mean, if the tissue is blanching and is depigmented, I mean, they could be hypoxic. I mean, one of the major things too you want to look at is the lips. I mean, I had a patient the other day come in and the lips were like purple. And I'm like, is that normal? Is that something that you see? Maybe you should see your physician for that. So some of those things I see in the chair, and I definitely, if it's something that looks abnormal or I don't know what it is, I do refer to either a physician, oral pathology, or oral surgery. Most of the times, what you're going to see on the gum tissue is going to be within normal limits. I mean, the variation in like African American or a Black patient will have different pigments in their tissue, and that's not abnormal for them. A Caucasian patient may have, I would say, between a Hispanic patient, I mean, and a Caucasian, maybe Hispanic patients may have a darker tissue tone, but a lot of the times, I mean, you could actually see melanoma, not so much on the gum tissue, but you can actually find melanoma sometimes in the roof of the mouth. So that definitely should not be there. If you see a freckle on the roof of the mouth, I mean, that's a concern that should be brought to oral pathology, or that patient should be referred to oral surgery for a possible biopsy. Purple tissue on the roof of the mouth is also not normal. A raised purple lesion on the roof of the mouth could be an indication of Kaposi sarcoma. That should be referred. Red tissue at the edges of the gum line could be also an indication of erosive lichen planus. There's really no treatment for that, but it could be painful for the patient. There's so many different, I mean, oral path was definitely a beast when I was in dental school, but there's just so many different conditions that can be diagnosed in the oral cavity. And it's not just limited to the gum tissue. I mean, it's limited to, it could be tongue, soft tissue, the buccal soft tissue, the cheek soft tissue. Just trying to think of any like white lacy things. I mean, also, this is a good one, tissue that is peeling on the gum tissue or blistering. It could be pemphigus, vulgaris, or bolus. I mean, pretty scary stuff.
Thank you, doctor.
You're welcome.
Another question we had was, what are the different anesthesia options when you use for patients' veneers? So like local anesthesia or completely putting them out?
Yeah, so I don't sedate my patients. I do give an oral sedative at times, which is like a Valium or something. It's very low in dosage, 0.5 milligrams. So I do give that so that, it's obviously once the patient take it, I can't reverse it, but it's such in a low dosage where it's not going to cause any harm. So sometimes I do offer that to patients because they may be nervous or something like that. Other than that, most of the time, what I use is a Septicane. Normally 4%, 1 to 100,000 epi, or 1 to 200,000 epinephrine. I used to use a lot of lidocaine, but I personally like how Septicane is quicker acting and doesn't last as long for a patient versus a lidocaine. It takes a little bit longer to act, but it lasts longer. So it just depends on what you're using the anesthetic for. There's also carbocaine, which is a pivocaine, which is 3% and has no epinephrine in it, which a lot of the times patients who are very sensitive to the epinephrine, which constricts it's a vasoconstrictor, right? It constricts the blood vessels. Some patients can have like a little bit of tachycardia, right? Because they get like patients who are anxious or patients who are really sensitive and get numb really fast. I use a carbocaine, or have any heart issues, I'll use a carbocaine. The problem with carbocaine is it doesn't last as long. So you're having to repeatedly give the patient anesthetic. But my go-to would be a Septicane, either 1 to 100 or 1 to 200,000 with epi. And epi is great because, there's going to be heme in dental procedures. So it helps with the heme and it helps with the acting of the anesthetic.
Thank you, doctor.
You're welcome.
Another question we had was, many of your case studies showed mostly adult patients. Do you ever work with the pediatric population, or is that generally like a different specialty?
No, that's a great question. So I personally do not treat children. I treat adolescent to adult patients, and it's been actually a really nice. It's been really nice for me because there's pediatric dentists for a reason, right? They know how to do the behavioral management and know how to speak to the pediatric patients. And I just really love the adolescent and adult. I'm able to connect with them, learn how to, behavioral management aspect for me from an adult perspective. I know how to handle that pretty well. And it's just my ideal patient and my patient niche that I really like working with. On occasion, I see sometimes 12, 13, 14-year-olds, unfortunately. And when I say unfortunately, I mean because sometimes they have to come see me. And when they come see me, it's not good because that means they have rampant decay everywhere. I mean, decay almost on every single tooth. And I'm basically filling every single tooth. And some of those kids have root canals, and sometimes at the early age of 14 need crowns. So when I see them, it's not a very good situation for the patient, for the parent, and for me, because I feel really bad. But yeah, I do prefer to treat adults.
Thank you so much, Dr. Torres.
You're welcome.
I'll now be passing it off to Hamza to finish off the rest of our Q&A.
Sure. Let's see. I think I got that question though. It was like 0.2% of sodium fluoride is the effective, that question to the answer to your question, sorry, about the fluoride.
Hello, Dr. Torres. My name is Hamza. I'm doing a joint BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine. And I'll be asking the last few questions that we have today.
Sure.
The first question that I have is something from our pre-dental students. How do you prepare for the DAT? Do you have any tips for the students currently studying for it and applying for
Yeah.
dental school in the upcoming cycle?
DAT, yeah, that was a long time ago. So DAT, I used personally, I used Kaplan. I used all of the Kaplan study materials. I did Kaplan classes in person, and I also did Kaplan tutor virtually. So that was what was most effective for me. I mean, there's so many resources now. I mean, God, I mean, there's I forget what it's called, but that's the DAT Destroyer. I mean, there's a ton. But that's what personally I used. I used the books, the practice quizzes, the lectures in person, and a tutor that I had twice a week.
Thank you, Dr. Torres. Our next question is, what is training like for dental students, and do they pursue residency after graduating from dental school?
So normally for D1, D2 year, it's going to be a lot of didactics, a lot of lectures. You're taking a ton of credits. Your second year, you're going to start taking sim lab, which is laboratory, basically dental lab, where you're, preparing teeth, learning how to prep teeth, all of that, along with classes. So second year can be very intensive. Third and fourth year is basically classes and clinic. You're actually starting to see patients. And in some instances, you start to see patients early as D2 year. So that's basically dental school in a nutshell. What was your other question?
The other question is, do they pursue residency after graduating from dental school?
I would highly recommend either A, you find a practice that is going to be willing to coach and mentor you through procedures. The problem has become with dentistry, especially with the pandemic, is that the requirements for dental school has significantly decreased because of pandemic. So a lot of these students that are graduating with very little requirements necessary, meaning they're doing less procedures. So either A, you go to a practice that's going to mentor you if you have any questions or anything like that, or I highly recommend that you do a residency. A residency in the sense that you either do a GPR, which is general practice residency, which is going to be hospital-based, which you'll do, depending on what you like to do, you'll probably do a lot of extractions, maybe some implants, some general dentistry. You will be doing ER rotations, or you do an AGD, which is an advanced general dentistry program, which I did, which is going to be mainly focused on the general dentistry aspects. You'll do some extractions. You won't be doing ER rotations or anything like that. And normally not hospital-based, but can be hospital-based, but your main focus will be patient care. So those are the two that I'd recommend if you just want to go into general dentistry. However, residency is required, or I should say specialty programs are required if you want to specialize like in orthodontics or endodontics, oral surgery, oral pathology. So that is necessary, but it's not necessary that you do a residency for general dentistry. However, it is recommended these days.
Right. Thank you for the answer. Can you tell us some more about the role of imaging when it comes to correcting patient bite alignments?
Yeah, so I mean, that has changed quite a lot. And orthodontics is not my specialty, so I'll give you more of a broad answer than a detailed answer. But I mean, cephalometrics, which is a cephalometric machine, there's different points on the face that you could use to correct bites, whether the issue is a skeletal issue, or whether it's a bite, like an actual tooth issue. So some patients may need surgery to correct their bite, meaning their jaw may need to be positioned forward, or their palate or their maxilla might need to be expanded and or move forward, depending on which jaw may be deficient. So that image there is going to tell you that. It's called a cephalometric image. The other thing that is pretty cool is called like an iTero or 3D scan that now they do of the teeth, which actually move the teeth digitally. So Invisalign is a great example of that. Invisalign has partnered, or also known as Align, has partnered with Itera, which is a 3D impression scanner, which scans the teeth and then is able to move the teeth digitally and see your progress 18 months, 24 months later, and you're able to do corrections digitally as well. So dentistry has advanced in that sense that you're going to see robots come on the market. You're going to see robots being able to place implants soon. Actually, they already have a robot that's able to place implants. I think the product is like $220,000. So yeah.
Thank you for the answer. The next question is, how can a dentist pursue roles in admission communities at dental schools?
Oh, how can you pursue an admissions committee for dental school?
Yes.
So for me, how I basically, when I was a student, I actually was on the admissions committee, on the admissions board. So when I was a D4 at Howard, I was actually asked to be on the admissions committee because I was like, I finished my requirements early and I was top of the class. So I was able to participate in those type of extracurricular activities. At Tufts, the reason why I was able to go on the admissions board as a resident was because I served the admissions board at Howard already. But if you're a student looking to become on the admissions board, it's a simple, just you could also ask your professors or show interest that you're interested in becoming a board member of the admissions. The other thing is if you are if you want to be on the admissions board at a school and you're a dentist now, I believe you have to be some type of part of the faculty in order to qualify. So you would have to be a faculty member at the school in order to be on the admissions board, but I could be wrong.
Thank you very much. And for our last question, Dr. Torres, how do you manage your work-life balance?
Oh, you learn that in school. Highly recommend that you learn that in school before you go into like the real world. But I think one of the major things for me, how I manage my work-life balance right now, it's like I went from 5 days to 4 days. It's like knowing what your happy, like what your happy workday load is like. And what's really nice about dentistry is that you're able to create, you're able to create that, right? You're able to create your schedule, how many days a week you want to work and stuff like that, how many hours you want to work. But it's pretty simple. I tend to get up early. I like to get up early and I have a schedule that I like to do. And I still do that from dental school. So I wake up maybe 5:30, get up, get dressed, eat breakfast. I listen to personal development videos and or podcasts on my way to work. Try to get a journal session in either at work or before work. And then after work, I come on my way home. I also listen to podcasts and personal development videos in the car. I use it basically as a learning experience. And then come home, either go to the gym, come home, read a book, and just get better. I mean, I try to get better daily, and I highly suggest that you do that as well. And especially in medical and dental school, you have to create a schedule that's going to work for you. So yeah, that's how I stay on top of everything.
All right, thank you very much for all those answers. Those are all the questions that we have for today, Dr. Torres.
Awesome. Awesome.
Thank you very much, Dr. Torres. We truly appreciate you taking the time to answer questions and as well as your book recommendations. They were very helpful.
Oh, you're very welcome.
We would love for you to host another session in the future if you'd like, and this was a greatly informative learning session for all of us. I'd love everyone to please give a warm thank you to Dr. Torres in the chat box for this incredibly informative session. Thank you.
Thank you.
Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live. And again, you'll need a 70% or higher to pass and receive certification. The deadline has been extended to a full week for you guys to take it. And that link should be in the chat now. And many of our students have expressed interest in pursuing a leadership position in teleshadowing, and we do have positions open on our leadership page as well, as we strongly believe in extending opportunities to others, and that link is in the chat now. And don't forget to join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox. You can join from the link in the chat now. And now on to our next session dates. I'm looking forward to seeing you all at our next session next Saturday on November 13th at 10 a.m. Eastern Standard Time with our physician mentoring us in emergency medicine. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Thank you so much for everyone. Thank you so much to everyone for attending today's session, and we hope to see you in upcoming sessions as well. And this concludes this week's shadowing session. Thank you.